Hello, everyone. Welcome to Being Patient Live Talks. I'm Mark New, hosted Being Patient. Today, we have some important topics to explore with our guest, Dr. Anna Chodos. She's passionate about helping primary care teams serve patients in detecting dementia and caring for people living with dementia. She serves as Executive Director of Dementia Care Aware, an organization dedicated to supporting nationwide primary care to improve dementia detection and care. She's also a professor of medicine in the Division of General Internal Medicine at Zuckerberg San Francisco General and the Division of Geriatrics, both within the Department of Medicine at UCSF. Anna, thank you so much for joining us.
Thank you for having me so much. Thanks for this opportunity to talk to everybody.
Sure. And first thing I wanted to have you just define, can you define cognitive decline in plain language for patients and families?
Absolutely. And I just want to acknowledge there's a lot of terminology out there. Some of it's fairly descriptive, but it's not necessarily precise. So there's a lot of terms and things that we hear. So, and they all overlap. And I like to say that the terminology around dementia confuses everyone, not just folks getting or with the diagnosis. But cognitive decline, I mean, it really is just referring to that change, that delta, if you will, from where we were, kind of like what we expected of our brain and our cognitive performance, and now, so that we've had some sort of decline. And in a clinical setting, we're probably talking about hearing the person tell us about some symptoms that indicate they're having real difficulty in areas where they weren't before. So I think that's a really key piece. Like, is this a change from a previous baseline, basically, like how they were before? And sometimes we measure it, and the measurement sometimes comes when people do like those tests, like a cognitive test with a doctor or a psychologist or something like that. So sometimes we like kind of quantify it, almost like you would a blood test. Like we do these tests to really understand how the brain is performing. And sometimes we might use it just after somebody's reported some symptoms. So it's kind of like a bucket of just a general reference to that you're not the same as before.
And what are some of the earliest changes in memory or thinking that families are most likely to notice first?
Wonderful. What we usually think about is how normal is their symptoms. And so I just want to point out every organ, for the most part, including your skin, including your kidneys, may have some change in function and reduced function, and your brain is no different. So we shouldn't expect necessarily our brain to be the same at 80 or 90 as it is at 30 or 40. So there is some natural cognitive decline in various areas. But when we talk about abnormal cognitive decline, some of the earliest symptoms really depend on what's going on underneath. There's not necessarily a pattern that everybody follows. And we think of different, it's sort of a short menu of different types of things that might happen. But most often, people think about memory. I think that's kind of the hallmark domain, if you will, or like thing that our brain does. Is people will often notice some differences, like they can't quite rely on their memory as much as they used to, let's say to keep track of like a grocery list or to remember a recent conversation with a family or friend. And that is because the most common cause of significant cognitive decline that's like turns into dementia, essentially, the most common cause is Alzheimer's disease, and that disease in most people presents with short-term memory problems in the very beginning. But many brain health type agencies or Alzheimer's Association or the Association of American Academy of Neurology, they'll have a list of like the 10 most common signs. And often it's things like forgetting recent conversations, misplacing things, leaving stuff on the stove, I think is another, sometimes what will be the most noticeable. So sometimes I think early is just the most noticeable is kind of what, but people will also sometimes have a lot of behavior change, and that will get lumped into like depression or anxiety, but really it might be an early sign of what's underneath it, which is a more sort of whole brain condition, or a condition that's going to lead to more of a dementia picture. So I guess what I would say to people maybe who are concerned or thinking about it or seeing it in family members, really the most important thing is this a change? Anything that's really a change for that person in any way that they used to be, in their behavior, in their memory, in their ability to speak, in their ability to move or use their body in space. Like some people fall, and that's one of the earliest signs. Um, just bringing that to the attention of a doctor, because it could be something that needs more evaluation.
Because so many people will, think that, oh, this, I'm just getting old. This is normal aging. Everybody says it all the time. Is it even hard for just regular doctors sometimes to be able to distinguish between old age and cognitive decline?
Yes. And I think one thing we're just dealing with, and it's part of the reason we have our program, Dementia Care Aware, is that, and I can't really give you a good explanation why, but is that a lot of medical providers, a lot of health systems don't really have a good system set up for early detection or for just like routinely checking in on people's brain health. And then a lot of doctors actually just weren't trained that deeply in how to recognize it. And then we add to it that if it's early, it's going to be more mild. So exactly what you're saying, is this normal or not? It's like really kind of mild. And that is totally acceptable really in some ways, because if it's milder, it's always going to be harder to really put your finger on it. If somebody's having a really clear big symptom, like they keep getting lost, I think that's something nobody's going to say that's normal, unless they were doing that before. I happen to be one of those folks who's very directionally not very equipped, but always seem to go the wrong way. But um, when there's a big symptom, that's always a tip off. But when it's these milder symptoms, that's when it's harder for everybody, the clinicians and the family. However, it is worth starting an evaluation. And I think it's worth bringing up, because if it is something, we now are learning more and more about how much we can do at the earlier stages. And so I think it is something we're trying to get everybody on board, healthcare providers, the system, and people in the community.
And what should people know, if they're worried about a loved one? I know we can easily say that, oh, they should see a doctor, but my own experiences too, with my mother with Alzheimer's, sometimes you go to doctor and experts too, and you just get, you know, sometimes we've had so many stories of people being ignored. Also,
Absolutely.
people getting the opposite, where you're getting overloaded with information. What are the steps to take in being prepared into going in that appointment so you can get the most out of that particular appointment?
Yeah, Mark, sorry, I got so excited by your last question. I also skipped, I think, some things that will tie the two together. First of all, I just want to say this is why we're trying to do our part to educate the clinical side of the house and the system to be more proactive in this area, to give doctors, primary care, nurse practitioners, and everybody, who's seeing patients, the tools to feel more comfortable figuring out, like, is this mild something, or is this really normal? But the most important thing is we're all going to have cognitive failures at some point. Like, you and I, I'm sure, can remember even 10 years ago, oh, I forgot a coffee cup on the top of the car. Or at that time, I lost my wallet. Like, a lot of these things are context specific. But the things that really start to, like, in my mind, or in my practice, come to real attention is when these symptoms are getting more frequent and they're getting more severe. I think those are some of the hallmarks of something, if you will, really going on. So yeah, I forgot that you told me that the other day, because honestly, I was distracted. I was in the middle of making, my grandson's lunch, and you were trying to talk to me about, something else. So I just totally missed the information. As opposed to, you were looking at me, we were having a great conversation, and somehow you don't remember what we talked about. And then I told you again, and you still didn't remember a couple of days later. That's a more, if you will, obviously kind of a more severe symptom. And it's one that's starting to be kind of more happening more often. So those are the hallmarks when I'm asking people what symptoms they're having. That's how I'm starting to parse not as normal from normal. So like occasionally it's happening in the context that makes sense. Like, I was really depressed. I had just lost my husband. And for 6 months, I didn't even know what was going on, as opposed to, no, I've been doing great. My mood is great, but I can't keep track of my appointments anymore. Or, apparently I'm forgetting my medicines. I'm forgetting to take them. I didn't even notice my daughter pointed it out to me. So these are different scenarios in the sense that one of them is really indicating a more severe pattern and one of a pattern that's kind of getting worse. That's where the not normal kind of features come in. And again, sometimes we do have to like manage up around the doctors and the healthcare system and saying, I understand, this is really mild. We are concerned. We know her really well. What we would really like to ask for is more of an evaluation, if that's okay, maybe some labs, maybe some brain imaging, because we take this really seriously, and just giving the clinician an extra motivation, if you will, to pursue a workup.
And can you walk us through what a basic cognitive assessment in primary care usually looks like?
Yes. So with this condition, I think, like you said, cognitive decline is a bucket. What sometimes I think we think we're talking about is dementia, and dementia is a condition where you have cognitive decline that's so significant that's actually causing day-to-day functional problems. So that is really these are the elements of the diagnosis or the workup, trying to establish what's going on with the cognitive symptoms, memory, language, behavior, ability to multitask, things like that, and what's going on with function. So those really should be and often are the two pieces that are getting assessed. And function means how are you able to get through, honestly, really basic things like shopping, cooking, taking care of bills, managing your medications, all the way to getting dressed, taking a bath on your own or a shower, things like that. So those are the kind of questions we ask, like, how are you getting these things done? How in your family are you guys managing the shopping and the cooking? Okay, so 5 years ago, she was doing most of the meal preparation, and now you guys have slowly taken over. That would be a significant functional decline. So I'm always trying to match cognitive decline with functional decline. And dementia is also still like a clinical diagnosis, kind of like depression, right? We don't have a blood test for depression. We don't really have a blood test for dementia. It's a clinical description of someone who has a cognitive decline and a functional decline. And we think that those things go together. So it's a lot of history. Usually it's some brain imaging just to ensure that nothing else is going on. Usually the brain imaging is normal, or maybe it might show some shrinkage or something like that. It's nothing super, fancy. It's really just that you're looking to make sure there isn't something that you miss, like a tumor or a big stroke, that, you would want to treat that person differently. And then some blood work. And sometimes people also have this cognitive testing if they have access to that. So there's a lot of them that we can do in clinic, and then there's some that we can order from specialists like neuropsychologists. And that's where, kind of like getting a study of your heart with the ultrasound or something, it's looking at the function of the brain. Like, how does the brain perform when you test it? And that's sort of what they're looking for. And they split it up into all different types of brain functions. And so that really helps us to, what they do is they compare that to roughly a normal, somebody without dementia kind of standard. So for someone who's 85, who was raised in the US and had a high school education, this is roughly where we'd expect them to be. And if they're way off, then the person might interpret that as they're abnormal in this area. So that can help us a little bit. And then we put it all together. It is a clinical diagnosis. And then we try, if we can, to tell people, why do we think it's happening? So we've now described that this is happening. What's underneath that? Is it small strokes, we might call, or big strokes, we might call that vascular dementia? Is it more looking like Alzheimer's disease? We call that Alzheimer's dementia, or Alzheimer's disease leading to dementia. Some people, and there's celebrities now who have this frontal temporal dementia or Lewy body dementia. That should be some of our work to put that together. And sometimes in primary care, that's harder because that gets into kind of specialty territory. But it can also be part of the conversation you're having with a patient if we have information that helps with that. And sometimes all we can say is, you have dementia, and really at the end of the day, we're not going to be sure exactly what's causing it. But of course, here's what we're going to do about it.
Now, what should patients and caregivers do if, they raise concerns and feel their worries are sort of being brushed off as just aging? And I don't know how often you see that.
I see it a lot. I actually talked to one of my really close friends yesterday about this. His mom, his father, who's a physician, brought it to his mom's doctor, and the doctor said, "Oh, I think she's fine." I mean, really didn't do much of an evaluation and said, "I think she's fine." And I obviously we can't 100% guard against something like that. We can't make the physician dive in or whatever. And there's a lot of reasons they don't do it. Obviously everything I described kind of takes a lot of time, and sometimes they feel they just don't have time. So this is like the managing up skills, as frustrating, I'm sure, on the patient and caregiver and family side it can be, to be like, why do I have to be somehow leading you to water here? But saying things like, I understand you think it's normal. We know her really well. We really think something's going on. It would really help us if you were able to do some evaluation. Um, I'll give you the example of my friend also. Their mom was like, "Oh, they think I'm crazy, and they're trying to get this evaluate." Like, she's starting to have some symptoms of, um, a little bit of anger and delusions, basically, that her family is not looking out for her best interests. So that's another thing to navigate. Like, it would really help us if you put this in the context of her health, and we didn't have to be the ones bringing this to you. And then I think just saying, we would do things really differently. We might move family around. We might plan differently. We want to get her legal situation set up, because that is actually the benefit of knowing earlier, all these things you can do. We want to get her into an exercise program and do that with her so that she's healthier, because we know that'll make her brain healthier. And I think just reminding the physician that losing that time is not good. It's not what most families want, or couples want, or people living with dementia want. They want more time with a healthier brain, and have the opportunity to be part of the planning process. And that's only there in the earlier and kind of early moderate stages, at the more, at the fuller degrees. So sometimes you can be pushy if that's your style, and I fully recommend that if you can manage it. I think also just appealing to the best interests of their patient, which is who they're looking out for, and just saying, we want her to do well. She's not going to do well if we don't know what's going on and we can't help her, and we really think something's going on, and just making it a point. And you can always share information with clinicians, even if the person themselves says, "I don't want you talking to them." Usually we need a permissions process to release information, it's called, to the family if we don't otherwise have that permission. Like, they're in the room and we've been granted permission, for example. So, but you can always leave a message for them and say, "Hey, we really noticed something. We really need you to bring this up." So just some strategies. I know they won't be perfect for everybody. And then the other one, of course, is, look for a clinician who is able to tackle it, feels equipped, or is willing to tackle it.
How often should older adults be screened for cognitive changes, and at what age do you recommend starting these conversations?
That magical number 65 is out there, because of Medicare, of course. So really, a lot of the approaches start there, and just say, at 65, Medicare has this annual wellness visit, which not everybody gets. It's not like perfect coverage across the country. Some clinics will offer it, some won't. But basically, we also see the risk of dementia, and the numbers just really start to go up at that point. So about 1 in 9, 1 in 10 in that age range will have it. And then as you get up to, everybody 65 and over, and then as you just concentrate in the over 80 range, it's more like 1 in 3, 1 in 2. So definitely everybody in that age range should be getting asked about symptoms and getting screened every year. I would also again, you want to try to catch it earlier. So also, mostly we recommend 65 and older.
Okay. And what do you think about the current state of education among, the medical profession, primary care, about looking for the signs? And then also we can talk about, once somebody is diagnosed, where to steer them, which so many people have. I ran into that issue too, of being pretty much
On your
left
own.
without, on your own. Do you think the medical schools and the systems are emphasizing that more? Are they not in a good state? Give them their grade right now.
Thank you for that provocative question. Yes, I wish we were doing better. I wish it so. I mean, on the positive side, I can be glad that we have our program, and it's a reason for my program to exist. But we know that the overall picture is like maybe a D. Most medical schools do not have geriatrics education, so education in the care of older people at all in general. So dementia is clearly concentrated in our older folks. We so it's important that it would be there. Obviously, neurology deals a whole lot with dementia as well, and they have a whole field of behavioral neurology, which is, of course, also a huge resource. But and most students have a neurology education, but there's so much else in there as well, and so it really should be more balanced. And then this general care of older adults is really beneficial in the approach to people living with dementia as well. So geriatrics education in particular is very poorly covered. We also are seeing, unfortunately, at the moment, federal scaling back of funding education in geriatrics in nursing, nurse practitioners, physicians, other disciplines, physical therapy, all those things. So that's another unfortunate reality. So we could be seeing aging and the fact that, yes, we're going to be living with people who have more people who are living with dementia in our country as an opportunity to grow sectors in caregiving, sectors in brain health, sectors in healthy living at any age and any ability. But that's not how we're really approaching it right now with policy and investments in education infrastructure. However, I think we're going to it is starting. The sense I get just anecdotally is that people really do see the need literally in front of them more and more often, and so they're reaching out more to get this education and this support. And we're catching up quickly with things like tools built into the medical record, or some AI enabled tools that help clinicians think through what they're seeing. So even if they have that knowledge gap, they have some resources that are highly accessible in the moment to help their patient. Dementia and cognitive decline, all these things really do need to be evaluated in a context of a clinical assessment. So it really needs that human being with experience and knowledge to really be doing thinking it through. This isn't a, sci-fi magical scan the body and they know kind of thing. Like, you really need to talk to the person and understand what they're going through and talk to the family and all that. So we really still need those efforts to support our clinicians on the front lines and train up everybody who's like kind of getting released now into the world as new doctors. So I'm hopeful that, like, I live in California, my state is investing a lot in dementia, and they've made some policy changes so that people who have both Medicare and Medicaid and are in certain plans have to be screened. That's a huge deal. So I think people will see and will feel that things are changing because some of these incentives are pulling them to have to know more. But so, like your program and the people who are joining us, it's obviously so important that people can advocate for themselves in this area. And because we know that folks who are having cognitive decline, before and into the stages of dementia, may not be their own best advocates because they may not even notice. This is a community issue. This is a family issue. This is a societal issue. So it's okay to advocate for your loved one or somebody you're concerned about. It may be the thing that gets them the care they finally need. So I admire everybody who's out there doing that. And really, sometimes I know it takes a lot of work, a lot of energy.
So a grade D, that's not too good, but what about in some other areas? And some of this is a little anecdotal. I think I believe I spoke to a relative Canadian, and I think they mentioned that some programs to sort of check up on people that were diagnosed, or to maybe to go in their homes to and see how they're living. But I remember them saying, like, see, why don't they have that here? Or, how are we doing that in the US? And is that an emphasis to, once somebody is diagnosed, to sort of follow up with them, maybe and visit their home, to see, their safety level, and what the prevention of, and things that need to be safe. I guess that's more occupational therapy, but programs that would follow up on a person, not to just leave them alone.
Yeah, well, we actually know that about a third of so about a third of older adults in the country live alone. About a third of those are have dementia and live alone. So as best we can tell from the studies that have been done in that area. And so that's actually quite a significant group. And I absolutely agree that would be amazing. There have been some strides in that area. So there is home health, and a lot of us order that. That's a Medicare benefit. And I think I probably didn't do the most complete answer to your last question, but one of the things that you mentioned, that people really feel alone after they get a diagnosis. I think part of the care is medical, but like a very large part of it is related to connecting to social resources, getting care in the community, connecting to these other fields of in healthcare like PT, OT, social work, and ensuring that people get connected to what they're entitled to and what they're able to be connected to. And that is actually another gap in medical care that sometimes we don't broaden our perspective enough. So a lot of people in the good news though is in a lot of ways, as people in society, we can DIY it a little bit more. Like we can reach out to these organizations, dementia themed organizations, if you will, or caregiver themed organizations. Like Alzheimer's Association has a lot of national coverage, but everywhere we live, there's often an Alzheimer's blank or dementia blank, organization, a caregiver resource center. And they often are almost better at starting at a more meaningful place and then helping people figure out what they really need and how to get those things. So highly encourage people to not be discouraged about the fact that maybe the physician or nurse practitioner, whoever's the primary clinician, isn't totally knowledgeable or totally excellent at connecting folks to all those resources. And then did I go to, the home visiting program. So Medicare started a program called Guide. It's a little tricky to find on the internet sometimes. If you just put Medicare Guide, you'll get no fewer than 100 million things. But you do Guide Dementia Medicare, and you'll find this innovations program. So they're doing it's essentially a trial across the country. And there may be one in your area. It has a way to look for one. And if you have dementia and you have Medicare, so what they do is they provide a care navigator, and that care navigator is actually required to do home assessments in the more advanced dementia. So not the mildest forms. They may often still do a home visit, or a virtual home visit or something like that, but they don't necessarily have to go all the way to the home. But they support the caregiver and the individual. For example, we have to connect the caregiver to peer groups. We have to connect the caregiver to resources if they want, of course, nothing's compulsory, but we have to be able to provide that caregiver with respite if they have that need. So somebody else to come into the home to relieve them for some period of time, at least once a year, we have like a small benefit to do that. I run one of those programs here in San Francisco. So I think that's a good milestone. And what they're looking for is, does that have, this is a classic thing, savings for Medicare. And if it does, they will probably make it a ongoing benefit, which is very cool.
Anna, thank you so much for joining us and sharing your knowledge and advice. I'm sure it'll be invaluable to so many of our viewers and listeners. I wrote down some notes when you were saying to follow up on that guide program. And I want to thank you so much for joining us. And thanks to our audience for tuning in. Don't forget to sign up for our newsletter, and where we'll keep you up to date on all the upcoming talks. See you next time.
Thank you.